Welcome to this explainer. Today, we're going to look at the operating room a little differently. We're actually going to treat it like a high-stakes flight, proving that a successful, safe landing depends almost entirely on the pre-flight checks. We're breaking down the essential protocol for preoperative assessment, and this is absolutely critical, whether you're studying for your medical exams or you're already standing on the front lines of patient care.
Let's jump right into a massive exam pearl that really needs to shift our entire mindset. It's incredibly easy to fall into the trap of bureaucratic box ticking, just blindly ordering a standard battery of blood tests and x-rays and calling it a day. But true preoperative assessment is a proactive, life-saving measure. It is all about identifying a patient's vulnerabilities and actually fixing them before the scalpel ever touches the skin. So here's our flight plan for today's explainer. We'll navigate the complex algorithm of preoperative care by covering winning before the incision, conducting the patient investigation, calculating risk, optimizing for success, and finally, clearing those ultimate safety checkpoints.
All right, phase 1, winning before the incision. We are setting the stage for safe surgery. Because just like you wouldn't dream of running a marathon without serious training, a patient definitely shouldn't go under the knife without rigorous physical and metabolic preparation.
You see, a true preoperative assessment isn't just a solo mission by the surgeon. It's a structured, deeply multidisciplinary evaluation. You're bringing together anesthesiologists, nurses, and specialists to really assess patient factors like frailty and BMI, along with specific disease factors and unique anesthetic risks, like a history of a difficult airway. It is a totally cohesive team effort designed to enhance recovery, facilitate shared decision-making, and fundamentally reduce morbidity and mortality.
Moving right into our second phase, the patient investigation. This is where we hunt for hidden risks. We're actively seeking out systemic dangers before they trigger a sudden, catastrophic emergency in the operating room.
This detective work builds into the standard preoperative assessment pathway. It kicks off with a comprehensive history and physical exam, moves straight through targeted risk assessment and optimization, and lands securely on informed consent in the surgical checklist. And the ultimate clinical pearl to remember here? This assessment is a continuous cycle. It literally does not stop until the very moment anesthesia is induced. Now, missing even one clinical red flag during that initial exam can completely derail a surgery. Uncontrolled hypertension, an active chest infection, unstable angina, or decompensated heart failure, if a patient presents with any of these, it is a massive screeching stop sign. You also have to relentlessly dig into their history for previous anesthetic complications. Things like malignant hyperthermia completely change your entire surgical approach. To actually quantify a patient's physical resilience and frailty, we measure their functional capacity in METs, or metabolic equivalent of task. This gives us a really tangible number to represent their functional reserve. It basically tells us whether their heart and lungs can pay the massive physiological debt that surgery is about to demand of them.
To put that into perspective, a patient operating at 7 METs or higher has excellent capacity. They can easily do heavy household chores or walk briskly without breaking a sweat. But, and here is an exam favorite and a crucial clinical warning, the simple staircase is actually one of our best diagnostic tools. If a patient cannot climb 2 flights of stairs, meaning they're operating under 4 METs, the risk profile absolutely skyrockets. They are at a highly increased risk for perioperative cardiovascular complications.
With our clinical clues gathered and MET scored, we transition into phase 3, calculating perioperative risk. This is essentially the math of survival, where we use standardized, heavily tested classification tools to clearly communicate danger.
You'll want to mentally capture the ASA physical status classification. It's the universal language anesthesiologists and surgeons use to stratify systemic disease severity. It ranges from ASA-I, which represents a completely healthy patient, all the way down to ASA-V, a moribund patient not expected to survive without the operation, and finally ASA-VI, a brain-dead organ donor. It's your absolute foundational tool for predicting baseline risk.
Now this brings us to a classic rapid-fire Viva question that trips up so many early career surgeons and medical students during exams. So think about it. Does the ASA classification predict surgical difficulty? Take a second. The answer is definitively no. The ASA classification has absolutely nothing to do with the surgical technique itself, or how difficult the local anatomy might be. It entirely predicts the anesthetic and perioperative risk to the patient's life.
Knowing those risks brings us to the most proactive phase of all, Phase 4, optimizing for surgical success. Think of this as the prehabilitation marathon, where we actively tune the patient's body to withstand the upcoming surgical trauma.
Managing perioperative medications requires surgical precision all on its own. We generally continue beta blockers and statins to protect the heart against perioperative stress. But we have to ruthlessly review and withhold blood thinners to prevent uncontrollable bleeding. We also stop specific diabetic meds like SGLT2 inhibitors to avoid severe perioperative ketoacidosis. Oh, and herbal supplements? Those need to go too, since they can unpredictably interfere with anesthesia.
You know what really separates a master clinician from an amateur? Avoiding unnecessary testing. Ordering blanket tests for every single patient is just a thing of the past. If you're ordering a chest X-ray, an ECG, or even basic blood work, it should be strictly based on that patient's specific history, their unique comorbidities, and their specific surgical risk. Individualized care is safe care. To supercharge recovery, we use ERAS, Enhanced Recovery After Surgery Protocols. By minimizing fasting times and using carbohydrate loading when appropriate, we actively prevent the patient's body from entering a starvation, catabolic state. Combined with early mobilization and multimodal analgesia, we drastically reduce hospital stays, and we do it all without increasing complication rates. It's a real game changer.
Okay, the patient is optimized, and we are in the final hours before the incision. It's time for Phase 5, the final safety checkpoints. We are cleared for takeoff. These bureaucratic guardrails actually serve as our ultimate life-saving safety nets.
Because the truth is, catastrophes in the operating room are rarely due to a single slipped scalpel. They are usually a cascade of entirely preventable errors. Ignoring anemia instead of treating it, failing to assess clot risk, sending a patient in with poor diabetic control, or missing a difficult airway. These are the hidden landmines that robust preoperative protocols are specifically designed to eliminate.
And before we even approach the theater doors, we need valid consent. Just getting a quick signature on a clipboard without real communication, that is a massive failure in patient care. Valid consent legally requires an honest discussion about the diagnosis, the proposed operation, the alternatives, and crucially, the material risks specific to that individual patient.
And here is our ultimate flight sequence, the WHO Surgical Safety Checklist. It happens in 3 distinct, non-negotiable stages. First, the sign-in, done right before anesthesia is induced. Second, the timeout, done before the skin incision. And third, the sign-out, done before the patient leaves the theater. This incredibly simple communication tool is proven globally to significantly reduce mortality and prevent absolute nightmares, like wrong-site surgery.
I'll leave you with this final thought to chew on regarding the incredibly proactive nature of modern medicine. We meticulously optimize machines for flight, but are we truly doing everything possible to optimize our patients before the scalpel ever touches the skin? Remember, a successful surgery is not just about brilliant technique. The scalpel is truly only as good as the preparation behind it. Thanks for joining me on this explainer, and keep these principles front of mind for your next clinical rotation or exam.